Welcome to the musculoskeletal system. In this lecture, we will be discussing several drugs that are used for the treatment of dermatological disorders. As you are all aware now, skin is the largest organ system of the body. It has uh, many essential functions that include serving as a protective barrier, helping to regulate temperature, offering defense against infections and toxic chemicals, serving as a source of vitamin D, and it provides sensation to touch, temperature, sexual pleasure, and pain. You are all aware now as well that skin is composed of two main layers, the epidermis and the dermis. The epidermis itself is composed of many layers and serves as a defense mechanism against foreign pathogens. The outermost layer of the epidermis, called the stratum corneum, consists of a lipophilic keratinous layer of skin. The dermis is located between the epidermis and the subcutaneous tissue and is composed of connective tissue. It also contains specialized structures such as sweat glands, sebaceous glands, hair follicles, and blood vessels. In addition to serving all those useful functions, skin also provides an additional route of administration, which is the topical route of administration, where the use of topical agents for the treatment of dermatological disorder is not only convenient, but also minimizes systemic adverse effects. Skin disorders such as acne and dermatitis are among the top reasons of why patients seek medical attention. They are very common diseases. And with the pharmacological approaches to correct skin abnormalities, including infections, can be either administered topically or sometimes don't forget that we would require systemic treatment of several skin disorders depending on the nature and the extent of the disease. This lecture will discuss drugs that are used for the treatment of common skin disorders including acne, bacterial infections, ectoparasitic infections, psoriasis, and pigmentation disorders. As we mentioned previously, several drugs can be administered topically, and these come in several preparations, including sprays, powders, lotions, creams, ointments, and gels. I'm going to leave it to you to try to figure out the differences between these different preparations. Importantly, the therapeutic efficacy of topical agents is dependent on several factors, including the thickness of the stratum corneum, which is the outermost layer of the epidermis. In addition to that, the drug concentration, the permeability, and the frequency of dosing, and other factors such as age and the health of skin all contribute to the therapeutic efficacy of topical agents. On the other hand, the bioavailability of these agents and their ability to retain that therapeutic effect involve factors such as the vehicle on which these drugs were prepared in. As you might expect, lipophilic agents or preparations that are oil-based are more readily absorbed through the skin than hydrophilic topical agents that are prepared in water-based vehicles. One of the challenges with topical drugs is that the dosing of these agents is not as controlled as with the intravenous or oral routes, and there are several factors that can govern how these drugs are applied to the skin. Let's start by discussing the first disorder in this lecture, which is acne vulgaris. Acne vulgaris is a very common disorder that happens in both males and females between the ages of 12 and 24 years old, which is a period that coincides with the increased synthesis and secretion of androgens. Clinically, acne is characterized by the formation of comedones, papules, pustules, nodules that can even progress into complicating scarring of the skin that happens usually in the facial area. Now, acne is a disease of the pilosebaceous unit. The pilosebaceous unit consists of the hair follicle and the sebaceous gland. Now, the sebaceous gland is responsible for the production and secretion of sebum, which is a waxy material secreted from the sebaceous gland that helps in the moisturization of hair and skin. What happens in patients who develop acne, and probably this is the most critical step in the pathogenesis of acne, is that their keratinocytes in the outermost layer of the epidermis will start abnormally differentiating and proliferating to occlude the pore of the hair follicle. Now, this hyperkeratinization or abnormal proliferation of keratinocytes will block the outlet that releases sebum into the outside. This results in sebum accumulation inside the hair follicle, and that is manifested clinically by the formation of comedones. Now, the problem is that when or following sebum accumulation in the occluded hair follicle, a species of bacterium called Propionibacterium acne, which is part of the normal skin flora, can enter the clogged pore and multiply, causing intense inflammation and leading to the papillary, pustularly, and cystic features of acne. And that is why the treatment of acne will be based on reducing hyperkeratinization, reducing sebum production, and controlling the infection caused by Propionibacterium acne. So we have two types of comedones clinically. Closed comedones, or what we call whiteheads, are what I just described, and they represent sebum collection in occluded hair follicles. However, in case these closed comedones become exposed to air, they become oxidized and their color turns into black, hence the name blackheads or open comedones. Several drugs are used for the treatment of acne. These drugs are mostly topical drugs that are administered directly on the acne lesions to the skin. However, don't forget that many of these drugs that are used for the treatment of acne are also administered systemically, such as oral antibiotics or certain retinoids. So let's start discussing the first family of drugs that are used for the treatment of acne. Retinoids are derivatives of vitamin A and are highly effective in the treatment of acne as well as other skin conditions such as psoriasis and photoaging. We have different generations of retinoids. Trichogenic and Isotretinoin are first generation retinoids that are used for the management of acne, while third generation retinoids, including adapalene and tazarotene, are less irritating, more effective agents than first generation retinoids and are considered first-line therapy for comedonal and inflammatory acne. These agents are all applied topically with the exception of isotretinoin, which is an oral drug. Due to the adverse effect profile, the use of isotretinoin should be reserved for those who have severe cystic acne. So let's now talk about the mechanism of action of retinoids. Retinoids influence a wide variety of biological activities, including cellular proliferation and differentiation, immune function, inflammation, and sebum production. The molecular actions of retinoids are mediated through the nucleic retinoic acid receptors. So let's take a look at how they function. At first, uh, retinoids circulate in the plasma bound to a carrier protein called the retinoid binding protein or RBP, and they become released from their bound protein at the target cell. Retinoids enter the target cell as retinol compounds that become then oxidized in the cytosol into retinoic acid. Retinoic acid binding to a carrier protein or retinoic acid binding protein inside the cytosol is then transported into the nucleus, and after its release, it binds to the inactive retinoic acid receptor. Binding of retinoic acid to the inactive receptor results in the activation of the intranuclear retinoic acid receptor. So the activated retinoic acid receptor complex acts as a transcription factor that binds to chromatin and activates the transcription of several genes that are involved in the regulation of cellular differentiation and proliferation. So several effects result from the activation of the retinoic acid receptor complex and the alteration of the transcription of many genes involved in proliferation and differentiation of cells. And these effects include significant reduction in sebum production, a reduction in the formation of comedones, as well as a reduction in the Propionibacterium acne population in the skin, in addition to the ability of retinoids to exert anti-inflammatory properties, and more importantly, to decrease the hyperkeratinization of skin. Now, unlike the first generation agents, the third generation retinoids do not influence sebum production, and they are usually comediolytic and anti-inflammatory in nature. On the other hand, isotretinoin, remember it's the only retinoid that is given systemically, produces a significant reduction in comediogenesis by decreasing hyperkeratinization. The exact mechanism of action of how isotretinoin achieves that remains uncertain, but there is no evidence that suggests that isotretinoin affects the metabolic activity of keratinocytes. Oral isotretinoin has no direct antimicrobial action, but by dramatically reducing the size of the pilosebaceous duct, it alters the microenvironment within the duct, making it much less favorable to the colonization by Propionibacterium acne. The result is a reduction in the population of Propionibacterium acne, which is a suppression that is greater than that seen with oral and topical antibiotics. It has also been suggested that, like all trans-retinoic acid, isotretinoin might increase host defense mechanisms and modifies monocyte chemotaxis, which is in part explains the strong anti-inflammatory effects of isotretinoin. The significant reduction in the Propionibacterium acne population also contributes to the extent of acne inflammation. And that's why isotretinoin is probably the most effective drug in the treatment of acne. Unfortunately, despite being very effective in the treatment of acne, retinoids have a very big profile of adverse effects which limit the use of retinoids. The most frequent adverse effect of retinoids, especially those that are applied topically to the skin, include irritation, dryness, and skin peeling, which are also adverse effects of orally or systemically administered retinoids such as isotretinoin. Photosensitivity is also an adverse effect, and that is why patients taking retinoid should be advised to wear sunscreen all the time. Other adverse effects include dry mucous membranes and dry eyes. That's why patients are advised to use eye drops. In addition to that, about 25% of patients on retinoid therapy will develop abnormal lipid metabolism that lead to hypertriglyceridemia and low high-density lipoprotein. This is usually because retinoid alter liver function, and many patients on retinoid therapy will have an elevated liver enzyme profile. The adverse effects of retinoids can be even more severe, to include suicidal ideation or suicidal attempts, amongst other psychiatric uh, symptoms that patients on retinoids can develop. Although these psychiatric complications of retinoids are usually more associated with the use of oral or systemic isotretinoin. The most probably important adverse effect of retinoids is that they are very teratogenic, and there is a very high risk of birth defects if pregnancy occurs while taking isotretinoin, and this drug as well as the other retinoids are contraindicated during pregnancy. In fact, there are multiple black box warnings for the use of isotretinoin, mainly because of its high teratogenic activities, and that is why there is a set of guidelines for the use of isotretinoin in females, where isotretinoin should not be used in females who are or may become pregnant because of this high risk of teratogenicity, which usually is associated with major cognitive disabilities, spontaneous abortions and miscarriages, or premature birth. Isotretinoin must be discontinued immediately if the patient becomes pregnant, and that is why, in order to avoid such a complication, female patients of the childbearing age must be taking or must be on a contraceptive method, probably two, in order to prevent unexpected pregnancy while on isotretinoin therapy. So before isotretinoin is administered or given to the patient, several laboratory tests need to be done, and these include a comprehensive liver function test done one day before starting the therapy and a comprehensive fasting lipid profile. In addition to that, and more importantly, female patients that are about to take isotretinoin must provide 2 negative pregnancy tests prior to the initiation of therapy. While the patient is on isotretinoin therapy, the dermatologist usually monitors liver function and lipid profile either weekly or biweekly until the effect of isotretinoin is established. Additional tests include checking for blood glucose and doing a psychological evaluation. Female patients would be required to provide ongoing negative pregnancy tests throughout the period of treatment. In addition to retinoids, there are several other drugs that are also useful for the treatment of acne, and these are usually more frequently used for the treatment of mild to moderate acne. Of these drugs, benzoyl peroxide is considered the first-line agent for mild to moderate acne that is not complicated by severe infection or inflammation. The mechanism of action of benzoyl peroxide includes antiseptic effects against Propionibacterium acne, as well as its ability to open occluded pores. Benzoyl peroxide is a topical agent that is available in many over-the-counter acne treatment products, as well as in some prescribed drugs. And it's associated with a low profile of adverse effects that are associated with local skin dryness, peeling, and irritation. Azelaic acid is a naturally occurring dicarboxylic acid that has antibacterial activity against Propionibacterium acne, and that is why it is widely used for the treatment of mild to moderate acne vulgaris. Its main mechanism of action is that it is able to inhibit protein synthesis of Propionibacterium acne, hence its antibacterial effects. It also exhibits anti-inflammatory potential, and it can inhibit the proliferation and differentiation of keratinocytes, which results in the reduction of comedogenesis. Unfortunately, azelaic acid has some adverse effects, and it is can be associated with mild transient pruritus, burning, stinging, and tingling sensations. But it has an advantage that allows for its use in a certain population of acne patients. Topical salicylic acid penetrates the pilosebaceous unit and works as an exfoliant to clear comedones. Its comedolytic effect is not as effective as those of topical retinoids, and that is why salicylic acid is reserved for the treatment of mild acne. It also has a mild anti-inflammatory effect and is keratolytic at higher concentrations. Salicylic acid is available in many over-the-counter facial washes and medicated treatment pads. It can cause side effects such as peeling, dryness of the skin, as well as local irritation. Since Propionibacterium acne plays a major role in the pathogenesis of acne, use of antibiotics is very helpful for the treatment of acne. Remember that Propionibacterium acne is a gram-positive root and is susceptible for a wide variety of antibiotics. Those are usually either tetracyclines or macrolides, protein synthesis inhibitors that are able to reduce the population of Propionibacterium acne in the skin. The most frequently used topical antibiotics include erythromycin and clindamycin. These are usually combined with benzoyl peroxides, azelaic acid, or other retinoids. Remember here, it's very important to remind you that the treatment of moderate to severe acne is usually combinational, that includes the use of retinoids, benzoyl peroxide, as well as antibiotics. Now, in certain situations where infection is not controlled with topical antibiotics, the use of systemic or oral antibiotics is encouraged, and the most frequently used oral antibiotics are doxycycline, minocycline, and erythromycin, although erythromycin is usually associated with gastrointestinal upset and is not as frequently used. However, the use of oral antibiotics, especially for a prolonged period of time, for the treatment of acne has been associated with increased risk of bacterial resistance, and there are definitely better approaches to the use of oral or systemic antibiotics for the treatment of acne. Once the effect of antibiotics is established, the patient can be maintained on topical benzoyl peroxide treatment. Since we are on the topic of antibiotics, let's move on to discuss several topical antibacterial agents that are used for the treatment of skin infections. Remember that species like Staphylococci and Streptococci can cause a variety of skin infections, including folliculitis, abscesses, cellulitis, impetigo, amongst others. And all of these bacterial infections of the skin tend to be pus-forming. Several gram-positive and gram-negative bacteria can cause infections that are not limited to the skin and may cause serious diseases since they can spread and become systemic infections. So it's important to remember that while the use of topical antibacterial agents is useful, sometimes skin infections can be severe enough that they will require hospital admission and the use of systemic antibiotics. Let's just take an example of such bacterial infections to the skin, which is impetigo. Impetigo, which is commonly caused by streptococci or staphylococci, in addition to MRSA, begins with a single erythematous macule that rapidly evolves into a vesicle or a pustule that then ruptures, and the released serous contents dry and leave a crusted honey-colored exudate over the erosion. So this feature is characteristic of impetigo. Impetigo often affects children. So we can classify topical antibacterial agents based on their antibacterial spectra. For example, bacitracin, mupirocin, and retapamulin are three topical antibacterials that are effective in the treatment of gram-positive skin infections. Bacitracin is a peptide antibiotic that is active against many gram-positive organisms. It is used mainly in topical formulations because systemic preparations of bacitracin are highly toxic, and hence this drug cannot be used systemically. Bacitracin is mostly used for the prevention of skin infections following burns, cut wounds, and minor scrapes. It is frequently found in combination products along with other antibiotics, usually those that cover gram-negative infections, such as neomycin and polymyxin. Bacitracin is also available as a single agent in ointment preparations. The next drug that is useful for the treatment of gram-positive skin infection is called mupirocin. Mupirocin is a protein synthesis inhibitor that is effective in the treatment of skin infections caused by streptococci or staphylococci, including methicillin-resistant Staphylococcus aureus or MRSA. It is available as a cream and as an ointment. It can also be given as intranasally to eradicate colonization with MRSA in patients who are MRSA carriers or those at risk of infection in the hospitalized setting. The most common adverse effects of mupirocin are pruritus, skin rash, and burning. Retapamulin is a protein synthesis inhibitor that is also active against streptococci and staphylococci. It is indicated for the treatment of impetigo and only available as an ointment. Okay, now moving to topical antibacterials that are effective against gram-negative infections, starting with the drug polymyxin, which is a commonly used drug for the treatment of skin infections caused by gram-negative bacteria. Polymyxin is a cyclic hydrophobic peptide that disrupts the bacterial cell membrane. And this, as you can tell now, unlike most of those agents that are effective against gram-positive bacteria that tend to be protein synthesis inhibitors, polymyxin is a cell wall synthesis inhibitor. Polymyxin is often combined with bacitracin, as I mentioned before, as a double antibiotic that has a wide spectrum coverage against both gram-positive and gram-negative bacteria. Neomycin, on the other hand, interferes with bacterial protein synthesis and is active primarily against gram-negative organisms with some activity against gram-positive organisms. This agent is often formulated with other topical anti-infectives such as bacitracin and polymyxin to treat skin infections. Common adverse effects of neomycin include contact dermatitis, erythema of the skin or redness of the skin, skin rashes, and urticaria. Remember that neomycin is effective in the treatment of Pseudomonas skin infections that can actually be very severe. Ectoparasites are parasites that live on the skin of animals from which they derive nutrition. These are usually either pediculosis caused by lice infection or scabies caused by Sarcoptes scabi. These diseases are actually very common in Jordan, especially in the peripheral areas where people come in contact with animals. Lice infections can take out several forms depending on the causative organism, and they can be caused by pediculus capitis, resulting in head louse, pediculus corporis, which results in body louse, or thyrus pubis, which results in lice infection of the pubic area. There are several agents that can be used for the treatment of ectoparasitic infections. This is very important to know, especially for general practitioners that will be treating patients in the peripheral areas, especially in farmers' communities. Of these, lindane is a toxic substance that, when absorbed by the parasites, it results in pediculocytic and scabicidal effects. So it's effective against both pediculosis and scabies. Permethrin is a synthetic pyrethroid that is neurotoxic to lice and is effective in 5% concentrations by prescription to treat scabies. Permethrin is preferred over lindane for the treatment of lice and scabies, since lindane can also cause neurotoxicity. Note that oral ivermectin is an alternative treatment for lice and scabies. Synergized pyrethrins with piperonyl butoxide is a non-prescription product approved to treat head and pubic lice. So pyrethrins are pesticides. They're highly neurotoxic to lice, and piperonyl butoxide prevents the lice from metabolizing and clearing pyrethrins. So when piperonyl butoxide is combined with pyrethrins, it enhances the anti-lice effect of pyrethrin. Due to a low risk of toxicity, this agent is considered the first-line treatment of pediculosis. Lastly, crotamycin is a scabicide and has antipyretic functions. Its mechanism of action is unknown, and it's one of the most commonly used drugs for the treatment of scabies. The color of the skin is derived from melanin, which is a chemical substance produced by melanocytes in the basal layer of the epidermis. When the melanocytes are damaged, the melanin levels are affected, which ultimately leads to pigmentation disorders. If the body does not make enough melanin, the skin becomes lighter, or what we call hypopigmentation, which is often reflected by disorders such as vitiligo. And on the other hand, if the body makes too much melanin, the skin becomes darker, resulting in hyperpigmentation. Pigmentation disorders can be widespread and affect many areas of the skin, or they can be localized. Agents for pigmentation disorders include methoxysalin and hydroquinone, which are used for the treatment of vitiligo and hyperpigmentation skin disorders, respectively. So let's start talking about hydroquinone. Hydroquinone is a topical skin whitening agent that reduces hyperpigmentation that is associated with freckles and melasma. Melasma is a brown to gray skin discoloration that frequently happens with aging. Hydroquinone is often used in combination with other topical drugs such as retinoids to treat the signs of photoaging. Photoaging is skin hyperpigmentation that happens due to aging. The mechanism of action of hydroquinone is through blocking the enzyme tyrosinase. Remember from your biochemistry that melanin is synthesized from tyrosine or tyrosine-like substances, and inhibition of the enzyme tyrosinase is a critical step in the mechanism of action of hydroquinone. Inhibition of this enzyme results in a reduction of melanin pigment production and the reduction in skin coloration. Hydroquinone lightens the skin temporarily and is commonly used as a 4% preparation. It should not be used in higher concentrations or for a prolonged period of time because hydroquinone can be carcinogenic if used in excessive quantities or for extended duration. The most common adverse effect of hydroquinone is skin irritation. Methoxsalen is a photoactive substance that stimulates melanocytes and is used as a repigmentation agent for patients with vitiligo. So the action of methoxsalen is the opposite of hydroquinone. So how does it exactly work? Methoxsalen must be activated by ultraviolet light to form a DNA adduct inhibiting DNA replication by a method called PUVA. So patients will be treated with methoxsalen on the lesions that show hypopigmentation, and then they will be exposed to ultraviolet light to activate methoxsalen. Methoxsalen, once activated, inhibits the proliferation and promotes the differentiation of epithelial cells, and that results in the stimulation of the melanocytic activity. So methoxsalen is an activator of melanocytes. And once melanocytes are activated, they start secreting excessive amounts of melanin, resulting in repigmentation. That's why methoxsalen is useful for the treatment of hypopigmentation disorders such as vitiligo, as well as psoriasis. Methoxsalen is available in oral and topical preparation and should be used with caution, similar to hydroquinone, because of a possible carcinogenic effect. Let's now move on to discuss the treatment of another skin disorder called psoriasis. Psoriasis is a chronic autoimmune skin disease that manifests as epidermal hyperplasia and dermal inflammation, which can range from mild to disabling. It is a condition that has a significant genetic association and it tends to come and go or to be activated or flared up by the exposure to several environmental factors, including stress, skin injuries, as well as exposure to intense sunlight. There are several forms of psoriasis, with the most common form is called plaque psoriasis. Plaque psoriasis is characterized by the presence of sharply demarcated, thick, erythematous plaques on the skin, as you can see in this picture. These plaques range in size from 1 square centimeter to several square centimeters. In mild to moderate cases, these plaques can cover up to 5% of total body surface area, but in severe cases of psoriasis, they can cover more than 20% of the total body surface area. Therapies may target inflammation or the inflammatory process associated with psoriasis and the consequent abnormal immune response, since psoriasis is an autoimmune disease, as well as it'll be targeted against keratinocytes to reduce epidermal hyperproliferation. Remember that because retinoids have a very potent activity in reducing hyperkeratinization and proliferation of epidermal cells, they are indicated also for the treatment of psoriasis. Tazarotone, which is a third-generation retinoid, is a topical agent that is used for the treatment of acne, but also very helpful for the treatment of plaque psoriasis. As we mentioned earlier, adverse effects of tazarotene are similar to other topical retinoids that we have discussed before. Acitretine is a second generation retinoid. Remember, this was not in the list of the drugs that are used for the treatment of acne. And this drug is used orally for the treatment of pustular forms of psoriasis, similar to oral isotretinoin, which we said is the most effective retinoid for the treatment of severe acne vulgaris. Acitretine is teratogenic, and women must avoid pregnancy for at least 3 years after the use of this drug because it has a very prolonged uh, uh, risk of teratogenicity. Patients who are on acitretine therapy should not be consuming alcohol. Uh, Adverse effects of this drug include pruritus, peeling of the skin, cheilitis, and hyperlipidemia. Vitamin D analogues can also be useful for the treatment of psoriasis, and vitamin D derivatives such as calcipotriene and calcitirol. These are synthetic derivatives of vitamin D, and they can be used topically for the treatment of psoriasis. They inhibit keratinocyte proliferation, they enhance keratinocyte differentiation, and they inhibit the inflammatory process associated with psoriasis. These drugs can cause side effects such as itching, dryness, burning, irritation, and erythema. In addition to vitamin A and vitamin D derivatives, several agents that are categorized as keratinolytic agents are also useful for the treatment of psoriasis, especially local lesions or local plaques of psoriasis. These keratinolytic agents, such as coal tar and salicylic acid, are effective for the treatment of localized psoriasis, especially that involving the scalp. These agents improve corticosteroid preparation. Coal tar inhibits excessive skin cell proliferation and may also have anti-inflammatory effects. Because it is cosmetically unappealing, as you can see in the picture, coal tar may have a low acceptance rate among patients, and consequently, its use has been largely replaced by the newer topical antipsoriatic agents. So it's not very commonly used anymore. Several drugs are used to target the inflammatory process that is involved with psoriasis, and one of those is the drug Apremilast. Apremilast is an oral agent that has been approved for the treatment of moderate to severe plaque psoriasis. Its mechanism of action is that it works by inhibiting the enzyme phosphodiesterase 4. And remember from your immunology and biochemistry, phosphodiesterase is involved in cyclic AMP signaling, and the inhibition of phosphodiesterase will result in a disturbance of cyclic AMP signaling, which is very important step in the regulation of inflammation, because cyclic AMP signaling results in the activation of NF-kappa B transcription and the transcription, synthesis, and release of many cytokines and chemokines that are involved in inflammation. The most common adverse effect of apremilast uh, are GI symptoms, including diarrhea, nausea, and headache. Some patients may develop depression, and apremilast, since it's metabolized by in the liver, it's a strong CYP450 inducer, and hence it has many drug-drug interactions. So in order to more selectively target the inflammatory processes associated with psoriasis, several biological agents have been developed and they have shown great success for the treatment of psoriasis. These are usually antibodies, whether monoclonal or polyclonal antibodies produced by DNA recombination technologies that target several processes involved in the pathogenesis of psoriasis. These are usually spared for the treatment of severe to moderate psoriasis. Examples on biological agents or antibodies that can be used to treat psoriasis include etanercept, infliximab, and adalimumab. You might have recognized these drugs already because these can also be immunosuppressants. Remember that psoriasis is an autoimmune disorder where immunosuppressants play an essential role in its treatment. All of these drugs target the inflammatory mediator TNF alpha or tumor necrosis factor alpha. Ustekinumab is a selective anti-interleukin 12 and anti-interleukin 23 antibody, and both these cytokines, both these interleukins are involved in the pathogenesis of psoriasis. So targeting them with specific or selective antibodies have been shown to reduce the severity of the disease. Guselkumab is an anti-IL-23 antibody that also has been shown to have an effect in the treatment of psoriasis and so on and so forth. Again, since psoriasis is an inflammatory disorder, then classical anti-inflammatories or classical immunosuppressant drugs such as corticosteroids have a great role in the treatment of psoriasis, and almost all patients with systemic psoriasis receive corticosteroids. You might remember that corticosteroids have a wide variety of uses, especially for the treatment of skin diseases, not only psoriasis, but also eczema, contact dermatitis, and other forms of allergic skin reactions. And as you all know, corticosteroids bind to the glucocorticoid receptor, which is a nuclear receptor that results in a wide spectrum changes in gene transcription, leading to inhibition of the arachidonic acid pathway, resulting in reduced inflammation, of course. They can also affect and reduce the transcription and synthesis of many inflammatory cytokines, as well as corticosteroids have been shown to reduce the rate of epidermal cell division. So they reduce the proliferation of epidermal cells. And that's why they are very helpful and a frequent component of the treatment of psoriasis. At last, we will be discussing the drugs that are indicated for the treatment of alopecia or hair loss. Minoxidil is an established drug indicated for the treatment of androgenic alopecia. It was originally developed to be an antihypertensive drug, but however, it was shown while patients were taking minoxidil for the treatment of hypertension that they would develop hirsutism or excessive hair growth as a side effect. So this adverse effect was then implemented and taken advantage of to use minoxidil to treat patients with alopecia. When minoxidil, which is now available topically, is used to treat alopecia, it does not cause hypotension, which would be an expected side effect of systemic minoxidil treatment. We still don't know what is the mechanism of action of minoxidil. It is thought that it will shorten the resting phase of the hair follicle because hair follicles have different phases of growth. And in resting phases, hair doesn't seem to grow that much. That's why minoxidil reduces that phase and speeds up the hair cycle. Unfortunately, minoxidil needs to be applied continuously to the areas of skin that have alopecia. The other drug that can also be used for the treatment of alopecia, which is available systemically through the oral route, is called finasteride. Finasteride is a a known inhibitor of the enzyme 5-alpha reductase, which is the enzyme that is implicated in the synthesis of testosterone. So inhibition of 5-alpha reductase results in blocking of testosterone synthesis, and it also blocks the conversion of testosterone to 5-alpha dihydrosterone, which is the active form of testosterone. And this helps in decreasing testosterone or dihydrotestosterone levels in the scalp. That's why finasteride is used to treat androgenic alopecia, in addition to its, of course, other uses such as benign prostatic hyperplasia, which you will be talking about in the genitourinary system. Some of the adverse effects of finasteride include loss of libido, erectile dysfunction, and it's definitely contraindicated in female patients that are pregnant.